Hello and welcome to your intrapartum lecture. Before we get started, I just want to go over a couple things first before we jump into the PowerPoint. So when we're talking about delivery or the process of giving birth, the birth of the baby is a life-changing event and a moment that the parents will remember forever. It is also such a special moment for the nurses to be a part of this whole process. I cannot tell you how many times I have cried during a patient's delivery because it's an amazing experience to be part of bringing another life into the world. And typically it is a joyous time for parents, but it isn't always, as we've discussed previously in other lectures about fetal loss and other complications or fetal anomalies that can happen. Um, with that being said, you still need to be caring, compassionate, be one of those nurses that's highly involved in the care of your patient. I always say that the best nurses in labor and delivery are the ones who are at the bedside and are staying in the patient's room with them during their labor process up until the delivery, not the ones that are hanging out at the nurse's station and not involved in the care of their patient. There are lots of things that parents must decide, decisions that must be made during their pregnancy, as well as planning for the delivery process and the birth of their baby. Firstly, they have to decide what type of doctor do they want to have. Do they want to have an obstetrician? Do they want a midwife? Do they want a support person such as a doula there? Who do they want in the delivery room with them? Pre-COVID, of course, we could have more than one visitor. Now it's just the support person. Do they want a male doctor or do they want a female doctor? Do they want more of a natural childbirth or do they want an epidural right off the bat? Do they want to deliver at home and have a home birth? Do they want to deliver in a birthing center or a more controlled environment such as the hospital? Also, other things that they might be thinking about, in developing a birth plan. Do they want to breastfeed their baby? Do they want a bottle feed? Do they want to do skin to skin immediately after delivery? Do they want to do cord blood banking, delayed cord clamping? Who's going to cut the cord? Um, there are various things that parents must decide, even with the newborn. Do they want them to get all the medications? Do they want them to have a bath while they're in the hospital? Do they want their baby to have a pacifier? All right, so what is labor? How do you know if a mom is truly in labor or if they're just having Braxton Hicks contractions, or what I like to call as practice contractions? Braxton Hicks contractions they can occur earlier in the pregnancy or start a few weeks before a patient goes into labor. And they kind of help get your body ready and start working the uterus muscle for when the time comes when you actually do truly go into labor. So Braxton Hicks, even though patients have them, they are not strong enough to cause any cervical change. So labor is defined as contractions that cause cervical change. And when we're talking about cervical change, that can be a variety of things. It's not just referring to dilation. So dilation is one of them, effacement or the thinning out of your cervix, softening of your cervix, because usually your cervix is very firm and hard and it softens out as you get closer to delivery. Even the position of the cervix. So typically it starts posterior and then it starts to move more midline and then even anterior when you get closer to giving birth and as the baby head moves down into the birth canal. Also, the length of the cervix, is the cervical length shortening? So, those are all things that we're referring to when we talk about cervical change. So, the difference between Braxton Hicks contractions and labor contractions is that labor contractions are regular. They are getting closer together over time. They typically last from 30 to 70 seconds. They continue despite any changes. So if the contractions don't go away when you rest, you go and drink a bunch of water, you're emptying your bladder, you're changing your positions frequently. If the contractions stay the same and do not change, then that is true labor. Versus Braxton Hicks, where when you do those things, just like we would tell you to do for a patient who was having preterm contractions, try all these things first. And if they go away, then you're okay. You don't need to come to the hospital. Um, Are they getting steadily stronger? Are they occurring more frequent, closer together, kind of getting into that regular pattern? And also, where are you feeling the pain? Typically, with Braxton Hicks, you may only feel them in the front of your abdomen, whereas with labor contractions, they start in the back and move forward to the front. It kind of wraps around your whole body. Sometimes this pain can also radiate down your legs, in the front of your legs. I've also had patients complain of like sharp shooting pain in their vaginal area. Those are all things that um, would cause you or would allow you to come to the conclusion that they're probably in true labor and not having false labor. So, when do you tell a patient to come into the hospital? Typically, you would inform them that if they're having regular contractions that do not go away with any of the change in movement, that are less than 5 minutes apart or 5 minutes apart or less, and if the contractions are getting stronger. Also, if they're starting to feel more pelvic pressure, having any difficulty breathing, like they get short of breath when they have a contraction, then those are all signs that you would want to let the patient know that it's probably time to come into the hospital to get checked out. So these are some other signs that precursor or pre-warning signs that you may be getting close to the time for delivery. We have nesting, lightening, any changes in your discharge. Did you lose your mucus plug? Are you starting to have um, mucousy, blood tinged discharge instead of just the normal white hormonal discharge? Did your water break? And are you having the frequent and strong contractions? If your water breaks, absolutely, you do not wait until your contractions are 5 minutes apart. As soon as your water breaks, you need to come in the hospital to be evaluated because of the risk of infection. We've kind of already talked about lightening before. That happens at the end of the third trimester. Some people say that's when the baby drops, or you can notice the change in the mom's abdomen, that the baby looks like they're sitting lower in the abdomen, close to the pelvis. And that's the baby's head's getting more closely engaged. So that's when the mom finds it easier to breathe, but then they have the more frequency or urge to get up and go to the bathroom because the baby's then sitting on the bladder. Nesting, what is nesting? Um, Nesting is one of those things that's more of an emotional, hormonal type thing that kicks in prior to labor, where the mom will get a huge, huge burst of energy prior to going into labor, where they know that they need to get a bunch of things done in preparation for the baby. So they'll go and set up the nursery, get their bag together, do shopping, make other arrangements if they have other children, and get everything set up before they go into the hospital and deliver. Typically, at the end of your pregnancy, you're exhausted and tired. But when nesting occurs, getting closer to labor, they get that extra boost of energy. And I kind of like this slide because it goes over probably all the thoughts that a woman, as well as her partner or support person, may be thinking or feeling, because you don't know, especially if it's your first child. You may be overwhelmed and excited and happy and can't wait, but there also may be some anxiety and fear associated with it, because you don't know what it's going to be like. You don't know how painful it's going to be. You don't know if everything is going to go as planned, and things to expect. So it's important for the nurse that when the patient first gets there, that they discuss what options or what the patient would like. So when a patient first gets admitted, they should inform the nurse then if they want to do the cord blood banking, if they want to do delayed cord clamping, if they want to do skin to skin immediately following, if the dad is going to be the one to cut the cord. And then also discuss um, their plans. Do they want to have an epidural? Do they want to try to have a natural birth? Do they want to get in the um, tub? Do they want to get up and move around? Do they want to take a shower? Do they want to use aromatherapy? All the different things, comfort measures that they're going to use throughout their labor process. Now is the time to discuss that with the patient when they're in that early labor phase, before it gets more into active labor, because during that time it's extremely hard for the patient, because of their pain, to focus and concentrate on what is being told to them or asked of them by the nurse. So it's better to provide all the education and discuss the plans on the initial admission, as long as the patient isn't already in active labor, which some patients do come in. All right, so now we're going to jump into the different stages of labor and what you as a nurse would do, or what interventions you're going to do to help the patient based on which stage of labor that they're in. There are 4 different stages of labor. You have the first stage, which comprises of 3 different stages within it: the second stage, the third, and the fourth. So during the first stage, that's when we're referring to cervical dilation, where the patient goes from 0 to 10 centimeters. Latent phase is also referred to as early labor, when the patient is only 0 to 3 centimeters. This is the time where the patient should be, what I recommend is staying at home. Stay at home for as long as you can before coming into the hospital. Why? Because once you come into the hospital, we like to strap you down in bed, put you on the monitor, get an IV in, then you're kind of restricted in your movements. And the latent phase is usually the longest phase, especially for first time moms. And so it's better to stay at home, because you can still eat and drink, you can get up and move around, you can do things that kind of distract you from the pain that you're having from your contractions. So I encourage patients or parents to stay at home for as long as they can before coming into the hospital, especially if you want to have more of a natural childbirth. That's not to say that coming in the hospital you can't have some sort of a natural labor and childbirth, but it's not the same as if you were to labor and deliver at home or even in a birthing center, because there are certain things that we do and policies that we have in place that prevent us from the patient truly having more of a natural labor. Like, we don't do water births in the hospital environment. Then the active phase is 4 to 7 centimeters, and then transition is when you're 8 to 10. And we'll discuss in a little bit on the next slides of how the patient looks or what they may be doing or how they're acting and what interventions you're going to be performing based on these stages. Because you will need to know what to do to assist and support the mom during the different stages of labor. Also, do you feed the patient when they are in labor? Can they eat or drink? Well, that depends on which stage of labor they're in. The second stage is what we refer to when you are completely dilated and then you deliver the baby. Third stage is the delivery of the placenta after the baby has been born. And then your fourth stage is when you're in the postpartum period, but it's the initial 4 hours after delivery. So that's after the placenta has delivered as well. So this slide kind of breaks it down into the 3 phases that are happening during the first stage of labor. How frequently their contractions are occurring, how long their contractions last, and whether it's mild, moderate, or strong. They're having mild, moderate, or strong contractions. So as you progress in the first stage of labor, your contractions kind of start out mild, where they're a little discomfort, mainly backache. And you're pleasant, you're cooperative, you're talking, you're distracting yourself. And you don't have a whole lot of anxiety during the latent or early phase. As you progress more into the active phase, your contractions are getting a little bit stronger, they're lasting longer. You may be wanting to get up and move around because it feels better laying in the bed. Your fear might be starting to kick in, and now instead of just having the back pain, you may be having more abdominal pain as well as suprapubic discomfort because the baby is now coming down lower into the birth canal. During the transitional phase, I don't want to say they're out of control, but they're more upset. They may be crying. They're not really paying attention to what's going on. It's more hard for them to focus because they're trying to um, focus all their attention on the pain that they're having. And a lot more anxiety during this time and fear because you're getting closer to delivery of the fetus. So this is when you have more severe pain, the pubic pain, pressure maybe radiating down your thighs. This is not the time that you would want to be educating your patient on things. You would have wanted to do that earlier because during this time, they're not going to be focused on anything that you're saying. So this is another slide where they're active. It just shows, because I love visuals, you want to be medicating them when they're 4 to 7 centimeters, assessing or anticipating their needs. They're going to be have dry lips, so you want to put Vaseline on their lips, or if they brought their own chapstick, encourage them to use that. And then during the transitional phase, when they're 8 to 10, they're exhausted, they're tired. You want to encourage your patient and encourage them to keep going and that they're doing great and it's almost over, and let them know how far along they are in the birthing process or how close they are to delivery. They may be restless and very uncomfortable. Most of the time, before you get to this part, depending on whether the patient wants an epidural or not, they may not be um, in as much pain. So it depends on whether these visuals and how patients act in their phase of labor, whether or not they got an epidural or different pain medications. If they're having a natural labor, unmedicated, meaning they don't have an epidural, these are more true to the picture of what a patient may be going through. So, do you think the fetal strips look different during these stages? Absolutely. So let's talk a little bit about what the fetal strip will look like during each stage or phase of labor. So think back on some of the terms and descriptions we went over in OB Lab. What would you expect a fetal strip to look like for a patient who is 1 to 3 centimeters dilated? It could be this first strip where everything here is normal, it looks great, it's a category 1, the patient's having accelerations. Then as you progress more into the active stage, you're going to start seeing more of the early decelerations. So these are all appropriate and normal process of labor. Earlies are a common finding during the active phase. Do you do any interventions? No. You just continue to monitor the patient and let them know that they're getting closer. The baby's head's coming further down into the birth canal, and this is absolutely normal. So variable decels, those can happen anytime. Remember, we talked about they're variable in nature, meaning they can happen with or without contractions. The ones that happen with contractions sometimes occur due to a nuchal cord where it's wrapped around the baby's neck, or if there's a knot in the cord. So what is the component in fetal monitoring that tells us the baby's doing okay? That they are adjusting their sympathetic and parasympathetic systems to changes. This is what we refer to as the variability. Remember, we talked about variability. It's the beat-to-beat changes that occur within the fetal heart rate. Doesn't have to do with the accelerations or decels. It's the wavy pattern that occurs between the accelerations. Variability indicates that the baby is not acidotic. So accels do not always happen. Why? Because babies have sleep cycles. But regardless of whether the baby is sleeping or not, the variability should always be present. So unless there is an issue, you should have at least moderate variability, if not minimal. Remember, we talked about you don't want the flat line because that means absent, and that refers or suggests that the baby is acidotic. So you want to make sure that you're assessing the fetal strip prior to administering any medications to start labor or as soon as the patient arrives to the unit if they are in labor. That's one of the first things you do while you're doing the admission history and going over all this stuff. Patient should be on the monitor so that you can get a baseline of what the baby looks like and what their contraction pattern is doing. You want to assess how the baby is tolerating labor and contractions, because once they start pushing, the strip can get crazy sometimes and it's really hard to interpret, as is what's showing down here on this last one, that these kind of spikes here on the contractions indicate that a patient is pushing. And you can see what happens to the baby during the time that the mom is pushing. Sometimes as the baby progresses even further down into the birth canal, it's hard to even trace the baby on the monitor. So sometimes all you have to go off of is how the strip looked prior to the patient pushing and the fetus's recovery after a contraction or when the patient stops pushing. So fetal strips are very important during the labor process, and it's important that you know during each stage of labor, whether they're in latent, active, or transition, how frequently we are monitoring the patient. So during the latent phase, every 30 to 60 minutes, they have to be monitored. Active is every 30 minutes, and then during transition it's usually 5 to 15 minutes is when you're looking at, assessing, and documenting on the fetal heart rate tracing. One other thing I wanted to mention about patient when it comes time for them to start pushing is that you let the patient do their own thing. They can breathe and push how they want. If they went to a labor birth class or Lamaze where they taught them different breathing techniques, um, or the blowout method, the he, and blowout, the best thing to do is let them do it how they want, because that's how they're going to be most effective at breathing during their contractions. The one thing that you want to remind them of or encourage them not to do is to hold their breath. So you want them to do some form of panting or breathing during pushing and not hold their breath, because when they hold their breath, that's what tends to cut off the oxygen and circulation to the fetus. But the mom can do whatever they choose to do. And so you don't want to be the one correcting them or redirecting them to do a different method. You want to encourage them to do what is working for them and how they are most comfortable. So, in the whole labor and delivery process, there are 5 different things that affect how the labor and delivery or the birth of the baby is going to go. There are 5 P's. We're talking about the passenger, the passageway, powers, position, and psychological response. When we get to the psychological response, that's where I'm going to talk about some of the interventions that you would do for a patient during these different stages of labor. So, what is the passenger? The passenger is the baby or the fetus. Um, in talking about passenger, you're referring to how the baby is lying in the mom's abdomen or their uterus or fetal lie. Um, if your baby is positioned this way, cephalic or vertex, that's where you want them to be. That means they're head down. Breech presentation, that means they're facing the wrong way and they will not be able to have a vaginal delivery if the baby is breeched. They would need to have a C-section. Transverse is where the baby's sideways, and then you have oblique. Sometimes with the oblique, if the head was down here and the butt was up here, sometimes as labor progresses, the head might rotate more midline and they may be able to deliver vaginally with this presentation. Not always. With transverse, this baby typically probably is not going to turn around either, and so they would need to have a C-section as well. When we're talking about breech deliveries, I kind of already mentioned previously that in the US, breech babies have to have a C-section. In some developing countries, that is not always the case. So, what I would like you to know about this is how the passenger in their position can cause a problem. What can also cause a problem is how the baby is positioned in the pelvis. And we'll talk about that in a little bit later when we get further into this. We'll go over fetal attitude and different presentations depending on how the baby's head is positioned in the pelvis. So this slide shows different forms of breech. So frank breech is the butt is the presenting part. In a complete breech, the butt is also the presenting part, but the legs are crossed. Whereas in the frank breech, they're folded up. And then footling is the foot is down. You can either have one foot or both feet can be down, and that's what we refer to as footling breech. And then these are when we were talking about position in the pelvis, complete flexion of the head, moderate flexion, poor flexion, more the baby's head is more extended instead of flexed forward. And then this is full extension where the head's all the way back. So it's showing here if the baby's got fully extended with their head, it's going to be a face, what we refer to as face presentation. The poor flexion here, this one is more of a brow presentation. Moderate flexion is still okay, but you can see when the baby's head is completely flexed, how much more extra room is here for the baby to move through the pelvis. So this is the position, ideal position that you want the baby to be in. It does not always happen that way, but when they're completely flexed and in the right position, it progresses the patient's labor a lot quicker than with these other presentations. So now this is another thing that we're talking about when you're determining the position by filling the occiput of the baby's head. So the occiput is the back of their head, and you can feel this when you go and do a vaginal exam. You can feel for the fontanelle on the baby's back of their head to determine what position they're in. So you have ROA, which is right occiput anterior. You have LOA, left occiput anterior. Right occiput transverse, left occiput transverse, right occiput posterior, and left occiput posterior. So when you have right or left occiput posterior, meaning the back of the baby's head is in the back position in the back of the mom's pelvis, this can make delivery extremely, extremely hard. This position can lead to prolonged pushing. When a patient's pushing for a long time, that can lead to maternal exhaustion. And then that may also result in the patient needing to have a C-section. So fetal lie doesn't just have to do with presentation, but also the position of the fetal head, meaning where their occiput is located. So let's talk, and I will go demonstrate this more in class to make it a little bit more clearer with the pelvis and the baby's head so that you guys can see it in person. If a baby were to have a face presentation, how do babies breathe after their umbilical cord is cut? Newborns are obligate nose breathers. So if their face is pushed up against the pelvis for 12 hours or more, then their poor little faces are going to get smashed, which can also affect their breathing after they are born. Can sometimes cause nasal congestion, and it may have an effect on how well the baby is able to breastfeed after delivery. So that's one thing that you want to keep in mind. And if the baby's having difficulty breastfeeding after delivery, you can discuss the reasons behind why it might be happening with the patient. So now we're going to discuss the passageway. This has to do with the pelvis or the birth canal in regards to the shape or opening of the pelvis. So you see how these points here line up with the tailbone or sacrum of the patient right in here. That is what, these are the ischial spines. So if we look at the baby, we are looking at the relationship between the baby's head in relation to the ischial spines. And this has to do with fetal station, which we've kind of talked about previously. So if the fetal head is right at the ischial spines, This has, wait. If the head is right at the ischial spines, that's 0 station. It can be above the ischial spines. It's documented as negative station. Once the baby's head starts to progress below the ischial spines, then it is documented as plus station. The passageway is also connected with fetal movement and rotation through the passageway. 70 to 80% of females have the gynecoid pelvis. That's the one here. And that's where, which is the nice round pelvis. This is the one that you prefer a patient to have because they're going to have the most room for the fetal head to fit through. The other shapes have a lower likelihood of the baby passing through. So if there's a problem with the passageway due to the shape, the patient will need to have a C-section. In talking about the birth canal, this brings us back to STIs. So if a patient has condylomas from genital warts, which is HPV, or active herpes lesions, then that can affect the passageway. You cannot use the passageway if it is compromised. So those are some other things that a physician would know about previously or prior, hopefully, so that he could appropriately plan which way this patient was going to, whether they're going to have a vaginal or cesarean birth. Typically, it would be a cesarean birth, especially with active herpes lesions. The warts, it depends on how many the patient has and how advanced their stage of growth was. So here's just some more things that we're referring to, the mechanisms of labor. When we're talking about how hard it is for a mom during labor, it's also extremely exhausting and difficult for the baby during labor. The baby is working just as hard. You see all these different movements. This is what we refer to as the cardinal movements, where they're floating around before they're engaged, then they start to distend and flex, then they do a rotation, they extend. You can see all the different maneuvers here. This is just as visual for you to see what the baby's doing as they're progressing further down into the birth canal. This is not something that you need to memorize, you just need to be aware of it. And when we're talking about suture lines, those, when you're doing a vaginal exam on a patient, that also helps you determine how the baby is lying in the pelvis, which way their head is turned, and the position of their head, and because you can feel the fontanelles and suture lines during a vaginal exam. And I kind of already mentioned this before. This is where we're talking about fetal station. So 0, you're at level with the fetal head is level with the ischial spines. That means they're halfway there. If they're -2, -3, they're still up higher, but they're going in the right direction. Once you get to the +1, 2, and 3, then that means your baby's getting closer and going, progressing through the birth canal like they should be. +3 is usually when the head is crowning, and as I've said before, +4 is on the floor. That means the baby's out, basically. So now we're going to talk about the powers. The powers refer to contractions or the mother's efforts. So contractions, if they space out, is this going to cause cervical change or labor progression, or do the contractions have to be regular and frequent? So no, if the contractions space out, you're going to need to assist the mother in augmenting their labor by giving Pitocin to get the powers back to the uterus by stimulating contractions. So sometimes a patient will be progressing in labor, doing just fine. They'll get to about 5 centimeters and then they kind of stall out and get stuck. And then their contractions aren't effective at causing further dilation. So if a patient gets stuck at 5 centimeters, sometimes that baby or the fetus may be stuck in the birth canal for hours, which can lead to what we refer to as molding of the head. And it can lead to caput, which is edema. And you guys, we've covered that a little bit in one of your clinical days. So usually you will see or feel an edematous spot of fluid on the back of the baby's head, the same size as the dilation. So once they come out and you see how large it is, you'll be like, oh, this patient was stuck at 5 for a while, because the size of the molding or caput is going to be the same as their cervical dilation. So when we're talking about powers of contractions, the uterine muscle occurs up at the top of the fundus and pushes down and contracts around the baby. That's what helps move them down into the pelvis and further into the birth canal. So you want to be monitoring on the monitor how frequently they're occurring, the intensity, and duration. If you don't have an internal monitor, you won't be able to measure the intensity, but you can palpate the patient's abdomen to see how strong that their contractions are. If they're effective and contractions are doing what they should be, it's going to cause cervical dilation and effacement. So the Valsalva maneuver is used during the second stage of labor when the patient is actively pushing. And this is where, previously I'd mentioned during breathing, you don't want the patient to hold their breath. That is during, prior to the second stage of labor when they're not pushing, you do not want the patient to hold their breath. You want them to practice more of those breathing techniques. But during pushing, you do want the mom to hold their breath. So you encourage the mom to take a very deep breath and then hold their breath. This is referred to as closed glottis breathing. And then push downward when the uterine contraction starts. And then after the contraction ends, then they take their breath and get ready for the next contraction. So position and psychological response of the mother. This not only has to do with the mom's position, but also with the cardinal movements of the fetus and how they are maneuvering their way down through the birth canal. So you guys have already learned about and got to practice some of the different labor positions and use the peanut ball and birthing ball in clinical. The peanut ball is absolutely amazing. It can help with the maneuvering of the fetus through the passageway. It helps widen or open up the mom's pelvis to make it easier for the fetus to travel down through the birth canal, as well as assisting with patient comfort and also delaying or decreasing the chance of the mom having a cesarean section. I will share some stories in class about the whole labor process and intervention and using all these things. And I welcome all of you who have had different experiences in labor to share them as well. One of the things with the peanut ball, we typically do not give that to the moms unless they have had an epidural. So we use the peanut ball for patients who've had an epidural. If the mom wants to use the peanut ball and they haven't had an epidural, they're welcome, but it's not one of the standard practices that we do. The birthing ball is more of a common thing that we use for patients who do not have epidurals, because they can get up and move around and get out of bed, and the birthing ball may be more beneficial to them because they're able to move around more. So the thing that you do not want to do or encourage a patient to do when they're in labor is to lay or sit in bed. You want that patient to be up, moving around and active and changing their positions frequently for as long as they can until they decide to have an epidural. Then, of course, they won't be able to get out of the bed once they have the epidural. But you are doing your patients a disservice by not encouraging them if they choose to stay in bed. You want to encourage them to get up and explain the reason and educate them behind the why. Patients who are up, moving, and more active and frequently changing their position typically have a shorter labor and will progress a lot quicker and prevent them possibly from having a cesarean section, because not only are you doing it for your own comfort, but you're also facilitating the movement of the baby down into the pelvis and through the birth canal. So when we're talking about other comfort measures that you can do for your patient, typically in the early stage of labor or the latent phase, they're chilled and relaxed. You don't have to do a whole lot of different things for them. But once they get into the active phase, they start moving around more and getting agitated because of the increase in pain. This is when you want to do some of these other interventions. Some people bring in aromatherapy, their own oils, they have different lotions, they play music, distraction, guided imagery, where you use a focal point. Some people will bring a ultrasound picture and they'll use that as a distraction. Acupressure or counter pressure on the patient's back if they're having a lot of back labor. Ice packs. Some patients want to get up and get in the shower. We do have a tub that they can get into. They can't deliver in that, but that helps with comfort as well. As we know, everyone's pain tolerance is different. And so you should never be judgmental or be like, oh, this patient's only 1 centimeter. How can they be in this much pain? We all perceive pain differently. And so if the patient wants to have an epidural as soon as they get there and they're only 1 centimeter, we don't discourage them. All you can do is provide guidance and educate them that maybe if they could try these other interventions, wait a little bit longer. Because we know that if you get an epidural earlier in the pregnancy, it can prolong the labor. With that being said, after you have provided everything to the patient and allowed them to make an informed decision and they still want to have an epidural, they can have an epidural. Also, in talking about pain management and different methods, the one thing that's important is that you set expectations, discuss the process with your patient, ask what they want or do not want during the labor process when they're in early labor. Another thing I wanted to mention is teens make decisions for themselves as well as their newborns. And it's also important to inform your patient and let them know that regardless of what they chose when they initially came in, if they change their mind later as they're progressing and the pain is getting more uncomfortable, they can change their mind at any time. So just because they come in initially with this set plan and it doesn't go as planned, it's okay. They have the right and the option to change their mind at any time. Though another thing that's important to mention regarding the epidural is that the patient, if they're leaning towards maybe deciding to get the epidural because their pain is starting to get more intense, that they need to let you know before it gets to the point where they're in significant pain, because we do have to bolus the patient with IV fluids prior to them getting the epidural, and we'll discuss in a little bit why that is the case. So sometimes labor can be short for patients and sometimes it can be extremely long for patients. Typically, the standard when for first time pregnancy in the first stage of labor. This is the longest stage. It can last from 6 to 12 hours, but it also can last as long as up to 20 hours. For a second or third baby, for the multipara patients, this stage may be somewhat shorter. During the active labor phase, that can last on average 4 to 6 hours, and then the transition period or phase lasts for anywhere from a few minutes up to 3 hours. So you just need to let the patient know that when they come in labor, that it could be a short amount of time, or it also could be 48, 36 hours. It just depends on the patient's body, the position of the fetus. There are a lot of different factors that go into how long a patient's labor is. And then another thing too, when the patient is fully dilated and they get to the point where they are going to start pushing, they need to be informed or discussed with how long that may last. Not everyone pushes effectively, especially if they have an epidural. Sometimes that can make it harder for patients to effectively push. So some patients can push a few times and the baby's out. Sometimes it can take anywhere from 2 to 3 hours of pushing. So during the patient's labor, they should be encouraged to rest frequently if they can, to save all their energy and power for when it comes time to push, because it may not be an easy process or a short process for them. So labor dystocia, what is labor dystocia? There's lots of different terms that they use for this. Typically, it's when your labor stalls out. It can also be referred to as labor dysfunction, prolonged labor, protracted or arrested labor, or protracted or arrested descent. Basically, there is something going on, something is not working. There's an issue or a problem with the 5Ps. So it's when you're talking about the issue with the 5Ps, there may be nothing that you can do. It just depends on what the particular issue is. Typically, when you have prolonged labor or labor dystocia, there is a higher risk of you ending up having to have a cesarean section, depending on what the cause is and whether you can fix it or not. So some things you can try if the contractions are not effective is what we refer to as labor augmentation, where you're giving medications to kind of help the patient's contractions occur more frequently and become stronger, to help them move the baby down into the pelvis. So pain relief in labor. There are a lot of different options and things patients can do to help ease their pain or provide comfort during the labor process. There are both medicated and non-medicated pain relief measures. So what are some of the non-medicated pain relief measures you can use in a laboring patient? Might have hot packs, warm shower, the hydrotherapy tub, massage, aromatherapy, position changes, the acupressure or counter pressure, distraction, guided imagery. Medicated pain relief, you have epidurals, spinals if they were going back for a cesarean section, narcotics or opioids, and the pudendal nerve block. The pudendal nerve block is not something that they typically do any longer for pain relief measures. Some of the old school doctors, this used to be common a few decades ago, but it's kind of gone away from practice. With the epidural and spinal, they numb you up to your breast line. So you will feel numbness all the way down to your feet. However, the patient will still feel pressure, tugging, pulling sensation, but they will not have pain. You do still want the patient to feel pressure so that they know where to focus their pushing efforts when it comes time to start pushing and delivering the baby. So which of these meds are going to affect the baby? Narcotics, of course, are going to affect the baby. So what would you expect the strip to possibly look like? Well, it depends. Sometimes when you get narcotics or opioids, just like us, we get sleepy, kind of groggy. It kind of takes the edge off the pain. It will not totally take away a patient's pain. So it might make the baby sleepy because it does cross the placenta. And so you might see the baby goes into more of a sleep cycle. So there might not have as many ACT cells. Um, the variability might decrease a little bit. And you're going to know that that was caused from the pain medication that you gave. And that's why it's always important to assess the strip prior to giving pain medication so that you know previously the baby was doing okay and the effect that it's possibly having now is from the medications that you administered. The spinal and epidural have no effect because they stay in the mom's spinal or epidural space, so it does not affect the fetus. And the pudendal nerve block is a local anesthetic. This is the same thing that could be done if the patient were to have an episiotomy or they had a laceration after delivery that needed repaired. So one thing I want to mention about the epidurals is that they do cause vasodilation. When you have vasodilation, that causes the patient's blood pressure to drop significantly. Sometimes it can lower the mom's blood pressure too quickly, which then is going to have an impact or an effect on the baby, and that will cause fetal decelerations. So it's not from the medication that you gave, it's because of the rapid drop in the mom's blood pressure. So what do you do or give to treat low blood pressure in a patient who has an epidural? Well, we give ephedrine and fluid bolus. So that's why it's important, and depending on what facility you work in and anesthesia preference, they will determine how much of a fluid bolus you give your patient prior to an epidural. When I was in labor, it was 2 liters. You had to give them 2 bags of LR prior, bolusum prior to an epidural. I think standard practice now is 1 liter of fluid, a rapid bolus of LR prior to an epidural. And that's why it's important to discuss that with the patient, because you don't want them to wait till the point where they're in such distress that they want it immediately. And unfortunately, you wouldn't be able to do that because you need to do that bolus ahead of time. So here are some of the IV opioids that we use and other different measures. Nitrous oxide is on here as well. That's a newer form that we're using here in the US. IV opioids, typically we give Stadol and Dilaudid during labor for pain. One thing you want to keep in mind is the timing of the administration of these meds in relation to not only the fetal heart rate tracing, but also to imminent delivery. So if the patient is like 8 to 10 centimeters dilated, you may not want to administer these meds, or you're going to be more cautious while administering these medications. Because what do you think the baby's going to look like if you gave these meds right before delivery? They're going to come out active, screaming, crying? No, probably not. They're going to be more floppy. They may have some respiratory depression, because these meds, as I mentioned, do cross the placenta, so they do affect the baby. And what is the reversal agent for narcotics? We typically give Narcan. So your question might be, would you give Narcan to the baby? So you guys don't learn about NRP, which is neonatal resuscitation, but they have removed Narcan administration to babies from their list of interventions because it may cause additional respiratory issues for the baby. However, if you are asked this question on NCLEX, the answer is yes, you would give Narcan to the baby. So moving on to nitrous oxide. This is also referred to as laughing gas. It is somewhat newer in the US, but it is used to help kind of take the edge off a little bit to make the mother feel more relaxed and also decrease her anxiety. Typically, at least in my experience, not very many patients use this as an option. It does. The one thing that's nice about it is patients can they control it, so they put it on themselves, then they take it off, and it wears off pretty quickly. And so it is another option that patients can use if they don't want to use the or have an epidural, or they're not quite to that point where they want an epidural. So now we're going to talk about labor induction versus labor augmentation. They are two different things. And in talking about that, one of the scores that hospitals use to determine whether a patient is appropriate for an induction is the Bishop score. So this is one of those things that unfortunately you will just have to memorize. The score is used to determine if the cervix is favorable or not for labor induction and whether or not labor induction will be successful. So what score is favorable and what score is not favorable? Anything less than 5 is not favorable. They will not allow a physician to schedule a patient for a labor induction if their score is less than 5, because the overall goal of the hospital is to prevent a cesarean section. So if the body is not ready or showing signs of early labor, then they will not bring a patient in for an induction. They will have to wait until their score's a little bit higher and they start having cervical changes before they bring them in. So when you're inducing a patient, the patient is not in labor. You are giving them medications to induce contractions and initiate labor. And then augmentation occurs when the patient has been in labor, but their labor has stopped progressing. So they just need a little boost to get their contractions going again, as well as increase the strength of their contractions. So now we're going to start talking about medications used to induce or augment a patient's labor. So we typically use prostaglandins to soften the cervix. The cervix needs to be soft and thin in order for the cervix to dilate. So you're typically going to start seeing effacement prior to dilation. Semen has prostaglandins in it, which is why patients are told or encouraged to have lots of sex to stimulate labor, because this is a natural process without the use of medications. So, of course, you do not want to encourage this if it is contraindicated for the patient because of a previa or if they have ruptured membranes. So Cervidil is this picture here that looks kind of like a smashed tampon with a long string attached. This medication is inserted into the vagina and placed at the posterior fornix, which is a small space behind the cervix. It will typically sit there for 12 hours unless it falls out on its own prior to that. After 12 hours, you remove it, and then you check their cervix in about an hour to see if it has softened it up, thinned their cervix out, or even caused dilation. If it has not, then it's up to the physician whether they want to place another Cervidil or if they want to choose a different medication such as Cytotec, and then maybe even, depending on if it did cause dilation, if they want to start Pitocin. One important thing to remember about prostaglandins is that when you give those, it can cause a patient to have a fever. So an important thing to pass on and report to the postpartum nurse after the patient has delivered is whether or not they received prostaglandins during their labor process, especially if it was closer to their delivery time, because they may have a fever if when they go to take the mom's temp. And it might be associated with these meds that we gave them while they were in labor and not necessarily an infection that's going on with the patient. These are contraindicated giving these forms of medication if the patient has previously had a C-section. So if they hadn't had a C-section, they've had vaginal deliveries, or this is their first pregnancy, it is safe and okay to give these prostaglandin medications. We'll talk about PIT and some of the risks and things you want to consider when you're administering this to patients in labor. So I want to go back a little bit to why you wouldn't give prostaglandins for a patient who had previously had a C-section. And the reason is because prostaglandins will compromise the uterine scar and possibly lead to a patient having a uterine rupture. So Cytotec, this is actually a GI medication, but they found that it causes the uterus to contract when given to pregnant patients. So most of the meds, as I've mentioned before, that we give in OB are used to treat other things. And one of the other important things to know is that when we administer any of these medications, because they do cause contractions, it can also cause hyperstimulation of the uterus, which is also referred to as tachysystole. So the patient might have too many contractions or contractions really close together, and it can also increase the intensity of a patient's contractions. So with Pitocin, it creates contractions or causes a patient to contract, and it helps also with milk letdown during breastfeeding. So some of the risk, can they have a C-section if they're given these medication? It depends on the type of uterine scar. So whether it's a transverse, lower transverse scar, or a vertical. If they have a vertical incision, then no. Oxytocin can cause an increased risk for C-sections due mainly from nursing mismanagement, meaning they keep going up on the Pitocin and not paying attention or not adequately being able to monitor a patient's contractions. That's why when I mentioned previously in lab and at one of the clinical days that if you're giving Pitocin to a patient, you have to know what is going on with their contractions. If you are not able to monitor their contraction pattern adequately for various reasons and they're ruptured, they should probably have an IUPC placed. If they are not ruptured and you do not have that option, then you need to call the physician and discuss other options, because you should not be increasing your Pitocin unless you can adequately monitor what is going on with their contractions. Because if you cause too many contractions, it can lead to an abruption or, as I mentioned, uterine rupture. Also, you want to be paying attention to the fetus and how their heart rate is and what their strip looks like. So if you have recurrent decelerations on the fetal heart rate monitor, then you're going to want to stop the offending agent. So if they are on Pitocin, you're going to want to stop the Pitocin infusion, or if they have Cervidil in place, you can easily remove the Cervidil. Cytotec, unfortunately, this is a pill that patients can take PO, or it's inserted vaginally. It's cut into small quarters and put into the back of the posterior fornix of the cervix. It dissolves, and this medication cannot be removed. So it's important that you, as I mentioned, know what is going on with the patient's contraction pattern. So Pitocin, it's a high-risk drug. You do have to have 2 RNs verify this medication when you administer it initially. Typically, it is used for both induction of labor as well as labor augmentation. So you would stop the PIT if their contractions were lasting greater than 90 seconds, or if their contractions were occurring less than 2 minutes apart, because that means they're occurring too frequently, and you're going to start seeing effects on the fetus. It can also cause a change in the mom's blood pressure and their heart rate. Hypertonicity of the uterus, we already talked about, where it causes overstimulation of the contractions, and then in turn it will affect the fetus. Once you start PIT, there's a whole algorithm that nurses use, but like every 30 minutes you're going up on the Pitocin. So that's what I was talking about, not increasing the dose unless you can properly monitor their contractions. So those are all chemical ways to induce labor. Now we're going to talk about the physical ways that or physical things we can do to induce labor. Have you ever heard of stripping your membranes? Typically the physician, this is something they will do in their office. They will perform a vaginal exam and they rotate their fingers 360 degrees a couple times to cause a separation between the amnion and the cervix. Amnion is referring to the amniotic sac. The risk for this is a cause to have the patient's membranes rupture. Another thing that they can do is insert these laminaria sticks. The laminaria is seaweed, and there's usually about 5 sticks that you insert vaginally and leave them in place. And this also is something that helps cause cervical dilation. Some other things they can use are the balloon or the Foley bulb. They'll insert LR to inflate the balloon into the cervix. It has an internal as well as an external balloon that applies pressure on the cervix from both sides, which helps cause the cervix to soften as well as dilate. Typically, once the patient gets to about 3 centimeters, the balloon will fall out on its own. So another thing we need to talk about is AROM, or artificial rupture of membranes, because this is also considered a form of induction. When they go in with the amni hook, that's also called an amniotomy. And rupture of membranes increases the release of prostaglandins, which is why it is considered a form of induction. And these are all things that they will do when a patient is more in the early stage or latent phase of labor to help get the process going. Now, keep in mind, previously we mentioned this before, if you have an STD or any other vaginal issue with concern about the baby delivering vaginally, you do not want to rupture a patient's membranes. Another thing to keep in mind, if the baby isn't engaged or the fetal station is high, like -3, meaning the baby's head is not engaged in the pelvis, it is not at the level of the ischial spines, you do not want to rupture a patient's membranes because of the risk of a cord prolapse. If they are preterm, if the patient has an infection in the amniotic sac, you also do not want to rupture their membranes. Things to look at when we're talking about artificial rupture of membranes. What is one of the first things you want to do after a physician breaks a patient's bag of water? You want to assess your fetal monitor. Why? Because there's a risk of cord prolapse. So if they do that and the patient has a cord prolapse, you're going to see the effects on the fetal heart rate strip. The patient will start, or the fetus will start having variable decelerations because of the cord compression. This applies to both artificial rupture or if the patient SROMs, which is spontaneously rupture membranes, meaning the water broke on its own without you doing anything. Another thing you want to assess is, I like this up in the right corner, taco. What time did their water break? How much? Was it a large gush or a slow, small trickle? What color was it? Is it clear? Is it yellow? Does it have a green, brownish tinge to it? And is there any odor associated with it? Could be no odor, could be a sweet smell, or it also could be a foul smelling odor if the patient were infected and an infection was not suspected prior to the patient's water breaking, or if it were to break on its own. So how do you know? Is it meconium? Did the baby have stool in utero because of fetal stress? Or is it choreo, which indicates an infection? So with meconium, if the baby poops in utero and the meconium's floating around in the amniotic sac, where do you think it all also goes in regards to the fetus? Well, if they're swallowing their amniotic fluid and then peeing it out and re-swallowing it, there's the potential that it can get in the fetal airway. So the method, when we used to have meconium aspiration syndrome, meaning the baby aspirated meconium into their lungs, they would go in after the baby was born and suction it out. However, this method is not commonly used and has been disproven to be effective per evidence-based practice. However, if you were to see this as an answer to a question on the NCLEX in regards to meconium in utero and what interventions as a nurse you would select meconium aspiration, suction them out. Also, another thing that they used to do but don't commonly do is an amnio infusion. So with the amnio infusion, they would insert the IUPC, the intrauterine pressure catheter, and infuse fluid back into the uterus via hooking up an LR bag with tubing to one of the ports on the catheter and insert fluid into the uterus. This is also something that NCLEX would test you on, and that would be one of the interventions, although we don't typically do this as standard treatment for meconium and amniotic fluid. But the thing to remember is NCLEX is about 5 years behind, and so a lot of their test questions have not been updated. So here is why it is so important to make sure that you confirm the dates when thinking about an induction, in determining a patient's due date, that you don't miscalculate because it can make a huge difference. And why you have early ultrasounds to help determine an appropriate due date or gestational age for the patient. So when we're talking about post-term, we're referring to anything greater than 42 weeks. Typically, your pregnancy lasts 40 weeks. Anything between past 41 to 42 weeks is considered late term. Post term is greater than 42 weeks. There's always an increased risk waiting this long. Post term can lead to a higher risk of the baby getting stressed and having meconium in utero. Your placenta also gets old with time and it starts to calcify, which is what these little white areas on the placenta down here in the corner represent. If it calcifies, it doesn't function properly. So remember, your placenta was only meant to last 40 weeks. Now, in the US, standard practice is we will not let a patient go past 41 weeks. They will be induced prior to that, because once you get past that 41 week mark, the significant risk to the fetus doubles and triples, and it can lead to fetal demise. So if you see that on a test question, post-term, late-term deliveries, the greatest risk associated with that is fetal demise, because your placenta is not functioning like it should. So when you're looking at your placenta, there's two sides. The dirty Duncan is the maternal side, and the shiny Schultz is the fetal side. So when we talk about the maternal side being dirty, that's because all the waste from the fetus is brought over to the maternal side. You want that nice, shiny, healthy side to be on the fetal side. So what happens to your placenta after delivery? It depends. Most of the time it just gets thrown away. However, different cultures, different patients have different religious practices, where some like to take their placenta home and bury it. Some cultures like to eat it. A newer thing in the last decade is encapsulating your placenta and ingesting the placental capsules. One thing to keep in mind with this, if you have any type of infectious process, group beta strep, other bacteria, HIV, active herpes, hepatitis, anything like that, if you encapsulate your pills and ingest them, then you have the potential to not reinfect yourself, but if you're breastfeeding, to infect the newborn. So you want to be careful about doing that and make sure that you're properly educated on those things before you choose those as an option. So as you can see, there's different lobes or different areas on the placenta. So these lobes sometimes can get stuck, tear off, and stay inside the uterus, which can lead to a postpartum hemorrhage. It's what we refer to as retained products of conception. So it's important to assess. The doctor will look at the placenta after it's delivered, turn it over, look at all the sides to make sure that it is intact. If a patient were to have chorio or infection in the amniotic sac, you would separate the amnion. You can see how this has the amnion or amniotic sac covering around the placenta. You would cause a separation and take a swab between the chorion and the amnion. Remember, the chorion is your placenta, and send it off for culture to see what type of infection it was so that you know how to properly treat the patient. So this one we already talked about. The white spots for calcification. You see these darker areas on this one down here at the bottom in the middle. That represents blood clots. And that's where the placenta may have abrupted and started to clot off the blood. So we've already learned a little bit about cord prolapse, and you got to practice this at your clinical days. When you have an umbilical cord prolapse, it's a medical or OB emergency. You want to call for help right away. Insert doing your vaginal exams to relieve pressure off of the cord, whether it's the fetal head or some other body part of the fetus. You want to relieve the pressure off of the cord. And this patient will not be delivering vaginally. They will have to have a cesarean section. You want to put the patient in Trendelenburg. There's other measures you can do. This one says knee to chest. We typically don't have time to move the patient in that position, so we just lay the bed down and put them in Trendelenburg instead. Remember, when you have a cord prolapse, it's cutting off oxygen to the baby. So variable decels and using your veal chop, that's cord compression, you're going to have variable decels, but also with this, if the pressure isn't adequately removed off of the cord, you may also have late decels because your placenta is not going to be functioning as well either because of that cutoff in circulation. So I kind of thought this little acronym was nice, and it helped navigate your way through a cord prolapse because it says call for help, organize delivery, relieve pressure, and then deliver the patient. Other interventions you can do is apply oxygen. That's another thing that you would want to do for these patients as well. So a precipitous labor or precipitous delivery is the opposite of prolonged labor. It means the patient comes in and delivers in less than 3 hours or very rapidly, maybe if they've been contracting at home. Sometimes we have patients who come in and the baby's already crowning, and so they deliver right away. You do not have to know the Friedman curve here. It's just showing you with moms, first-time moms, and then moms who have had multiple pregnancies, how the difference is in the frequency and whether or not this occurs. Moms who have a high gravida, so if they've been pregnant multiple times, 3+ pregnancies, or high parity, there's an increased probability that they will have a precipitous labor. Some of the risks when a patient comes in and delivers extremely quickly is an abruption. They can get cervical and perineal lacerations and sometimes fetal head trauma. Women who have had previous history of precipitous deliveries, they will typically be scheduled for induction so that they don't have this in their next pregnancy. These moms are also at a higher risk for postpartum hemorrhage. So now we're going to talk a little bit about instrument-assisted deliveries. You have the vacuum-assisted birth as well as forceps-assisted birth. Some of the old school doctors still do forceps. The newer generation are trained on vacuum and aren't skilled in using forceps, so that's why they've kind of gone out of common practice. They both have risk in using these instruments. They can lead to birth trauma, vaginal perineal lacerations or tears, fetal head injury, swelling. Forceps typically cause facial bruising. They increase the risk of the mom having a postpartum hemorrhage and sometimes can even cause nerve damage to the baby. We'll talk a little bit more about this and share some stories of experiences in class. So postpartum hemorrhage, why do we bring this up in the intrapartum lecture? Because patients are at risk immediately following delivery of having a postpartum hemorrhage. So this kind of shows you want to screen the patient to see if they're at risk on admission. So as soon as they come into the hospital in labor, you want to assess whether they've had a previous postpartum hemorrhage. What number of pregnancies is this for them? Do they have any bleeding or clotting disorders? Have they had a previous C-section? Is there only one fetus or is it multiple? Do they have twins or triplets? And then evaluate their labs. So you're always going to get a CBC on a patient when they're admitted, as well as a type and screen if they were to need blood. Fetal weight, BMI, fibroids, whether they are being induced or augmentated, if they have a previa or a low-lying placenta, if they have a placenta accreta. These are all things that can affect the risk of a patient having a postpartum hemorrhage. And the reason why you want to do this early on is so that you can anticipate or that the patient may have a postpartum hemorrhage, so you can have all your stuff and interventions in place for when it does occur. Postpartum hemorrhage is a medical emergency, just like the cord prolapse. You want to call for help right away. You never want to be the only person in the room because a patient can bleed out very quickly. Not all hospitals have a postpartum hemorrhage cart. Our facility does, as well as a postpartum hemorrhage medication kit that we keep in our Pyxis for easy access. The thing to remember about this is fundal massage is your #1 priority with a postpartum hemorrhage, because majority of the time it is caused from uterine atony, meaning your uterus is not properly or adequately contracting. So vaginal delivery, 500 or less. C-section is 1,000 or less for blood loss. Anything greater than 500 for a vaginal delivery or 1,000 for a cesarean is considered a postpartum hemorrhage. You can also have a postpartum hemorrhage from trauma to the birth canal, so lacerations or tears during the delivery, retention or retained fetal or placental tissue or products of conception, or if the patient has some type of coagulopathy or thrombin bleeding disorder. You're going to give medications for postpartum hemorrhage. Patient, depending on how much blood loss, may potentially need a blood transfusion. You would want to do an ultrasound to check to see if there was any retained products. That is something the physician will do. Bimanual massage is where the nurse is on the outside of the abdomen performing fundal massage, and the physician is in vaginally massaging the lower uterine segment at the same time. Interventional radiology or surgical intervention are later things that you can do if the previous measures did not help and the patient is still bleeding. And this is just, again, going over the treatments. You will need to know the medications used to treat a postpartum hemorrhage and what their contraindications are. So we give Pitocin during labor to initiate contractions, but we also give it postpartum to continue your uterus to contract to prevent a postpartum hemorrhage. Hemabate is given. This is an IM injection. It's contraindicated in patients who have asthma. Another important thing to remember about Hemabate is that it can cause diarrhea and a significant amount. And so usually if they give Hemabate to a patient, they also prescribe Lamodal. Cytotec because that also helps with contractions and is used in labor induction and augmentation. It is also given postpartum. Typically, it is given rectal. So 1,000 micrograms is the standard dose that will be given rectally. Methergin is another IM med that we can give to treat postpartum hemorrhage. It is contraindicated or avoided in patients with hypertension or those who have preeclampsia. TXA is tranexamic acid. It is given IV. It's another medication. This isn't in your textbook. But it's another newer medication that we give to treat postpartum hemorrhage. So when does a patient show signs and symptoms? It could be any time following delivery. Initially, after the mom delivers, you're doing frequent vital signs. So you're assessing the mom's vitals every 15 minutes. You're doing fundal checks every 15 minutes for 2 times. Then you're doing 30 minutes times 2 every hour until the mom is moved up to postpartum floor. And then they're doing it every shift. Postpartum hemorrhage is the #1 reason why women die in labor and delivery. And it is something that can be avoided if it is recognized and treated early. There's no reason why a mom should ever die in delivery from a postpartum hemorrhage. So you want to know the patient's risk factors so that you can plan ahead. When we were talking about interventional radiology, they will sometimes send them down there. That's where they embolize the uterine artery to cut off the blood supply to the uterus and slow their bleeding. And sometimes they might have to go back in, open up the patient, and evacuate the uterus, look around, make sure nothing's left in there, there's no tears or anything that they missed. So we've talked about this previously as well. What is the best way to estimate blood loss? You don't want to do a visual estimation of blood loss because most of the time we're not accurate at all. You always want to, whatever you have that has blood on it, whether it be the chucks, a pad, the sheet, a blanket, whatever you have there to that has blood on it, laps from a C-section, you would want to weigh that so you get a proper estimate of the patient's blood loss. And then you would want to monitor their labs to see how significant of a drop they had in their H&H. And this is just showing all the arteries that are connected to your uterus, all the way up to your ovaries. And the uterine artery here is the one that they would embolize to cut off the blood supply to the uterus. This is a picture showing the bimanual massage that I talked about. Yes, it can be very painful, so a lot of times you want to medicate the patient, IV medication before the physician were to do this. If you don't have time to do it prior, while he's in doing it, you would want to give them IV pain medication. The Bakri balloon and a Foley catheter, those are some other things. Bakri balloon is also considered a tamponade balloon. So that gets inserted vaginally up into their uterus. It's filled with fluid. And it kind of helps block or put pressure on your uterus and the arteries to cut off the bleeding. Then it's attached just like a Foley to a bag where the blood would come out into the bag and you would do INOs on the their output. Why do I mention Foley catheter? Why is it important? If a patient has a balloon in place, you also want to insert a Foley catheter. The reason being is the patient may not be able to get up and move right away, depending on what they had done. And you don't want their bladder to be full, because we talked about this before. When you have a full bladder, it pushes up on your uterus, displaces it, and prevents it from adequately contracting, which is not going to help the patient's bleeding situation at all. So you want to put a Foley catheter in so that it's draining continuously their urine output and further preventing complications with the postpartum hemorrhage. You don't need to know this. This is just kind of an algorithm that some hospitals use, showing where it tells you, depending on interventions and where the patient's at, what you're going to do moving forward in treating their bleeding so that they become stable. Another complication that can occur during the delivery process is a shoulder dystocia. It is also considered a medical emergency, just like your cord prolapse. So you're going to want to call for help. That's always the number one. Evaluate for an episiotomy, meaning do you need to make more room for the shoulder to come through. Some of the maneuvers we do are put them in the McRoberts position, and we'll show you that on the next slide. Apply suprapubic pressure. The doctor will do other rotational maneuvers to try to help get that shoulder under and out. You want to try to remove the posterior arm to see if that helps get more room to help get the shoulder. And then roll the patient to her hands and knees is another thing that you can have an intervention that the nurses can do. You need to know the risk of shoulder dystocia. So what patients are at risk? Babies who are macrosomic or LGA have an increased risk of having a shoulder dystocia. If the mom's pelvis is small and wasn't adequately assessed by the physician prior, or the patient had no prenatal care, you might not know. There's not enough room for that baby to fit through there. So what are some of the dangers of a shoulder dystocia? You can get umbilical cord entrapment, inability for the fetal chest to expand properly, causing respiratory issues. You can get brachial plexus nerve damage, or even severe brain damage or death due to hypoxia or acidosis if there's a delay in delivery. One important thing when you have a shoulder dystocia is that from the time that it is realized, you need to be watching the clock and monitoring the amount of time that it takes to get the baby out. The physician is the one that will be directing the RN in what to do in this situation. He will tell you when to apply suprapubic pressure. He will tell you to do all these different procedures, and unless he does, you shouldn't be doing them. So here's some of this is the McRoberts, where the mom's legs are flexed onto the abdomen. It causes kind of a rotation in her pelvis and hopefully opens the birth canal a little bit wider. You can see the nurses applying suprapubic pressure to the baby's anterior shoulder. So one important thing to remember or know about this is it depends on how the fetus is positioned and the way their head is turned, whether you do it on the mom's right or their left side, because you want to make sure that you're applying the pressure on the right shoulder. Zavanelli is another position or maneuver that the physician can do where they're kind of turning the head and then putting the baby back inside. Typically, depending on how far out the baby's head is, they may not be able to push the baby back up in the uterus and take the mom back for a C-section. It just depends. Every patient's situation is different. So now we're going to talk a little bit about cesarean section. There are pre-op meds that you would give the patient prior. Reglan, Zofran, and Bicitra are the standard ones that we give. Remember, EBL of 1,000 mLs or less is normal for a C-section. Anything greater would be considered a postpartum hemorrhage. You're going to want your patient to be NPO for 6 to 8 hours. A cesarean section can either be scheduled or an emergency. Typically, the mom will have less lochia or vaginal bleeding following delivery as opposed to a vaginal delivery because they will clean out their uterus with the laps. This is just showing the different incisions. Low transverse is the most standard common practice in the US. Low vertical incision or a classical incision. Classical is avoided if we can. It just depends on the patient's situation and what they're having done. When we're talking about initial newborn transitional care, we kind of went over some of this in your last clinical day, where you're doing skin to skin, you're getting their APGARs, checking their vitals, weighing and measuring, doing the initial assessment on the newborn, giving the newborn medications, cord blood banking, delayed cord clamping. These are all things that would be done after the baby has delivered. We already mentioned in one of your other lectures about the end-call delivery. That's where the fetus is born in the amniotic sac, which I think is really cool. I've never got to see one in person, but hopefully I will one of these days. And then lotus birth is a newer, more common thing that patients are doing. And it's where the placenta is left after the delivery of the placenta. Instead of clamping the cord and cutting the cord, they'll leave the umbilical cord attached to the newborn. So they'll leave it attached until the cord falls off on its own. Typically, this is anywhere from 3 days to 2 weeks. It just depends on when the cord falls off, dries up and falls off on its own. So with the lotus birth, I've only seen one patient recently do it. It's probably more so practiced for home births or in birthing centers. Some of the beliefs around it or benefits, which have not really been proven, are that it's gentle, it's less invasive transition for the baby from the womb to the world. It increases blood and nourishment from the placenta, decreased injury to the belly button. Sometimes it's done as a spiritual ritual to honor the shared life between the newborn and the placenta. Some beliefs are that it increases the iron and blood levels in the baby, prevents fetal anemia. APGAR, we kind of already went over that in lecture or in clinical, so I'm not going to talk too much on this, but it is done at the 1 minute or 1 minute and 5 minute of birth. And if it's less than 7, so 6 or less, you would want to do a 10-minute APGAR. So when we're talking about cord blood banking and delayed cord clamping, delayed cord clamping is now recommended and practiced globally. It's standard practice in most hospitals. It's shown to increase hemoglobin levels, improve iron stores over the first few months of life. It improves their red blood cell volume, improves their circulation, and helps decrease the need for a blood transfusion, as well as decrease the risk of the newborn developing necrotizing enterocolitis and an intraventricular hemorrhage. However, there's a slight increase in the risk of jaundice with delayed cord clamping, but the benefits still are considered to outweigh the risk. With the cord blood banking, it's totally optional. It's up to the parents whether or not they want to do this or not. It can be pretty pricey. And so this is something, if the parents wanted to do, they would have thought about this and chosen it and set something up prior to delivery with an appropriate cord blood banking facility. So you do need to draw, it's important the patient lets you know they want to do cord blood banking, because you do have to draw maternal labs on the mom prior to delivery, and then make sure that you collect the cord blood following delivery. So this is showing what a typical umbilical cord would look like, where it's fat and kind of plump and nice. And this is where it typically looks like if you wait to do the delayed cord clamping, when all the blood has gotten out of the umbilical cord and gone to the fetus. Oops. All right, I apologize. I didn't realize that was the end of the presentation. So that concludes your interpartum lecture. We will cover a lot of these concepts in more detail in class, as well as share some different stories of personal as well as patient experiences, and make it a little bit more fun and interactive. There's a video that we're going to be playing as well that will quiz you after, of a patient who was in labor.